Conversations with Iris. Here's your host, my loving wife, Iris.
Hola, mi gente bonita. Hello, beautiful people. And welcome back to another episode of Conversations with Iris. Because you know what? This is a podcast where we have great conversations and we like to slow it down, and where we breathe and we make room for real conversations about real things, about life and wonderful things that people are doing out there. Here we talk about healing, and not just in the body, but in the systems, in our communities, and how we see ourselves inside spaces that we're not always built in mind for. So it's very exciting. Let me tell you guys something. Today's conversation is going to be about cancer. Yes, the big C, but it's also going to have technology, truth, and that little thing I love to call dignity. Yes, you heard that. But hey, before we dive in, don't forget to subscribe, download, listen, and share this wonderful episode. And if this conversation, you feel it in your soul, that little spark, I don't know, sometimes you have a conversation, you feel a little tingly in your soul and your little heart there. If it resonates with you, leave your girl a review, a rating. It means so much. It continues to fuel this little podcast that I'm trying to grow, guys, but you guys got to help me. Please, please, please leave your girl a review. And of course, don't forget to show love to our brother podcasts out there, the Short Desk Podcast, my crew, my wonderful man out there, my hubby, his vision. He paved the way for this wonderful podcast so you all could hear me. So definitely tune in and listen to them every Thursday on all streaming platforms as well. All right, now, mi gente, let me tell you today about our guests. Oh, this is a good one. Let me tell you guys, because we're going to be talking, like I mentioned, cancer, technology, truth, and dignity. But we're going to talk about it in a way that actually just makes sense, okay? Think about that. Because our guest today doesn't just live in the lab. He lives in the community and in the data and in the lived experiences that he has had or has shared with others, especially in the intersections of science and humanity. And he is also a cancer scientist, which I love. A fierce nonprofit founder, health equity leader, and a STEM mentor, which I already love. And he is also, this is the part that I love, he's a Black healthcare advocate who refuses to let innovation move forward without people in the room and them to be recognized. I love that already. And what I love most about my guest is that he helps real people understand what AI is actually doing in healthcare. Ask yourselves that. Without that jargon, without that hype, and without the fear, that mongering, he dares to ask questions too many systems avoid. By bringing that dignity back into conversations we're often missing. Like we have no idea that we're just basically missing them. And when the system failed him personally, he did not stay silent, ladies and gentlemen. He turned that experience into purpose, advocacy, and what I love, action. Mi gente bonita, I am truly honored to welcome to Conversations with Iris, the brilliant, the grounded, and the powerful Dr. Eugene Manley. Welcome, bienvenidos.
Well, thank you so much. It's a pleasure to be on the show and to chat with you.
Yes. Oh my goodness. So glad that you're here. Seriously, I am a nerd for that. I love STEM research. Ooh, child, let me tell you, I just love it all. I am a nerd. I love school so much, and STEM research and, just healthcare in general has always been a passion of mine. So I love what you're doing.
Thank you. It's been a long road, but it's just something I was interested in science from an early age, and I did not know I was going to end up in a career in cancer. It just happened to be what shook out after all my training was done.
Oh my goodness. And I just want to delve a little bit deeper into that. You mentioned something good. You didn't realize that you were just going to delve into it. But you know what? I always like to start light, reflective, and maybe a little human up in here. If you could describe a season in your life right now, what would you call it? Do you feel like you have a sense or a season of clarity, a season of purpose, expansion, or alignment? Tell me, what's going on in that big brain of yours? Let's talk about that.
Right now, we're in a moment of clarity of purpose, clarity of mission, clarity of drive. Really, it's clear who I'm trying to serve, who I'm trying to help, and who my target audience is. And so we're just trying to amplify that and make sure that people can understand also how to navigate and advocate for care they are entitled to as well.
Oh, I love that. I could tell this is going to be a great conversation. So for our listeners just meeting you for the first time, let's go way back, Dr. Eugene. Can you tell us, who is Dr. Eugene Manley today? Because it's just not about titles. I want them to know, who is the man behind this wonderful purpose and mission, and what got you there?
Okay, well, if we go way back, I grew up in inner city Detroit. We were poor. I was first gen. I was the first one, to really go to college and grad school and do all of this stuff. But, I grew up as a chronic asthmatic. My dad was a heavy smoker, and he was out of the house after I was 3, but we knew where he was. But I think that exposure made me have chronic asthma and allergies. And so I was in the hospital between 20 to 30 times a year between when I was 5 and 10.
Oh, my.
And then I had to end up being a caregiver for my grandparents when I was 10 to about 16, 17. And then I just saw a lot of how healthcare was and wasn't delivered. And then as my mom, before she died last year, I just saw a lot of how healthcare was and wasn't delivered to her. And then as I worked in lung cancer, I saw a lot of patients, specifically Black and Hispanic patients, talking about how they didn't see themselves in materials or in events or get information about biomarker testing and trials. So the continuum of my life was just me starting out my own self, my own chronic conditions, and then seeing how care or lack of care impacted my family. But I also was a scientist, so I was a budding scientist. I didn't know I was a scientist, but my science department head in high school was really the first one that got me my first real research job. Oh, and then that was in leukemia. And then after I did that research job, I was hooked. So I did kind of research every summer after that. And even though I did my undergrad in mechanical engineering, I still was doing biomedical research, and then ended up at Boston University, working in a lung cancer project, and looked at combination drug therapies, microenvironment. But because I've gone back and forth between engineering and biology, because both interested me, I have a mechanical engineering and a biomedical engineering background. So I have this unique way of looking at systematic problems and looking at, at a cellular, molecular and tissue level, and then trying to understand why things work or don't work and what we can do to improve it or repair it.
Oh, wow. That sounds amazing. And you mentioned something very important, the systematic problems of it. Sorry, that's my microphone there. The systematic problem aspect of it. Let's delve into that a little bit, because it's very important, and this is where we might possibly jump into the AI aspect of it, the cancer, and what does it mean for people out there listening. Let's just get into that, because people hear AI, precision medicine, and genomics, and half of the time they're like, what the heck? Okay, but what does that mean for me? So let's go ahead and take it back to the systematic problems of it. And, in plain language, like, how is AI already shaping cancer care and the ways people might not even realize? Let's talk about that.
Let's even go more general first. Let's talk about how AI is impacting care delivery first.
Oh, yeah.
So, at a root level, AI is, just looking at large batches of data and then trying to determine if there are, linearities, variances, differences, and then using that to predict how something may or may not behave. That's very root level AI. But AI is already prevalent in healthcare. A lot of people don't realize where it shows up. But some examples are, and this is a good use, is where doctors, will see a lot of patients and they don't have time to chart as much anymore. So there are some software, like they have some mics that they can speak into, and it speak to text. So they'll speak it and then it'll just transcribe it in the chart, and they can edit the chart after the fact. So that saves them some time. There's AI in sort of chart review. But there's a downside of some of the AI in charts because, some insurance companies will just use AI to quickly deny, peer-to-peers or deny care delivery. So, but then other instances where there's AI, we can, in lung cancer, there's a group in Chicago and in Harvard that have tested an AI algorithm to look at lung cancer, chest x-ray, low-dose chest tomography scans. And this software was able to predict patients who up to 5 years later would have lung cancer based on a previous x-ray. Now, this data, I'm trying to keep this simple, was based on the National Lung Cancer Screening Trial, which was done, I want to say, early 2010s, like somewhere around there, 2010, 2015-ish. And they were looking at patients that were at high risk of lung cancer, which typically are people with a history of smoking. And they had a whole big study where they show that lung cancer screening could help detect lung cancer early. And so because of that study, lung cancer screening became approved finally. The only downside of that study is most of the people in that study were not African American or Hispanic. And so there was really questions about whether this study was broadly applicable. And some subsets of this data showed that African Americans actually benefited better if they were screened and actually had an earlier age at which you could detect the lung cancer. But that was never officially approved because that would upset some people. So, but the algorithm, but what this new software, Sybil, does, they were able to, take that set that was not diverse, and then they applied this on data of, a set of people from the University of Illinois Cancer Center in Chicago, which is a federally qualified health center. So they have a very, diverse and underserved population.
Yeah.
And they were able to show that in even this diverse community, that software was able to still predict people likelihood of having lung cancer up to 4 to 5 years early with pretty high accuracy.
Oh, wow.
And then they also tested this in an Asian subset. I think it was a Korean subset as well. And in a different population, they were also able to show that a scan from 4 or 5 years ago could predict when that someone would have lung cancer. Not so much when they would have it, but it could predict it at least up to 5 years in advance. So that's a responsible and good use of AI. But then we have some examples. Let's say, and this example someone gave me is someone wants to say they're going to set up a software or algorithm that wants to test, breast cancer, by mammogram or density of breast tissue. And they have this whole data. We got this great data set, and we can predict breast cancer. And my colleague said, well, what was this patient population? And there's a reason she asked this question. And he really could not really answer it. She said, how many of these people were Black? And he did not answer. Said, well, they weren't in the data set, but our data set is fine. And she was like, then it's not fine.
It's not. Yep.
And the reason being is people who don't understand his face, Black women tend to have dense breast. Dense breast is associated with much higher breast cancer risk. So then you can't develop an algorithm or product to say, well, we can predict breast cancer if you don't even have the population that is at greatest risk or has a higher, likelihood of having breast cancer. And so, but, this example is one of many where algorithms are designed by people not from the community or that lived experience or understanding the broader set of populations with the disease. And then they say, we got a solution, but then do you? And that's where you end up with stuff that looks great on paper, then it doesn't work. And then you have egg on your face because you didn't do your due diligence.
Oh, my goodness. So then that takes me to the question. You said they're not a fan of the community. That's where AI fails. But is there any solutions or anything that it's out there that's going to be coming out in society that the AI, you mentioned the algorithm, is it going to expand to different diverse communities, including Blacks, including Latinos? Are there any advancements where that's going to be set in place? Just out of curiosity, do you know?
We would love to see that, but unfortunately, things that impact care delivery on patient outcomes are never really going to be done for egalitarian purposes. So unless there's some, regulatory mandate that you must include diverse populations, it's unfortunately not likely to happen. So, now if you are doing your due diligence and you design your algorithm to test all these different populations, or at least those that are more likely to have a disease, then you've done your homework. But that's only part of it. But then, like I said, if you don't have a team or at least staff, and I don't mean just one person, but you need more than one person from that community, from, either a product side or a design side, but you also then need to, how are you engaging with the communities that have these disparities? If you just come in and say, oh, we have a product, we want to do a trial, but you spent no time building trust, they don't know who you are, and then your coordinators don't look like they're from the community, then you don't have a product that can be employed in the community.
Yeah, and the results are not going to be correct. They're going to be inconclusive, I feel like. I'm so glad that you brought that up, though. I mean, it's that correct. Am I thinking about this the same? For our listeners, yes.
Yep, that is correct. And this ties into the other question you asked about genomics and precision medicine.
Yes.
And so we, in the early 2000s, we had something called GWAS, which are genome-wide association studies. And there's a couple other genomic databases that had been used to sort of try to identify markers of disease and whatnot. And then they have all this data and they try to make a statement, but then this data is often not diverse at all. It's mainly a lot of European-based data. And so you don't even have these data sets that reflect the populations. And often the European data set is used as a reference genome. So let's say, I'm trying to give you an example without getting technical.
That's okay.
Let's say you are trying to assess whether a gene is more, prevalent or a higher risk of cancer. But if your genomic data set is all like, let's say 85 or 95% white individuals, you're going to have one answer. But then if the population that may have this marker is, 40% Black, you've missed all of them because your data set was not trained on that and you don't even have those samples. And so this is where we really, truly advocate that people think about who's in the data sets. Now, of course, we didn't have a lot of data samples back then. We still don't have a lot today. But if you don't include these populations, then it's hard to really then broadly say you have a solution or intervention. And the challenge is, precision medicine is really driving a lot of therapy for of advancements. But if the patients aren't represented, it's still going to exacerbate the disparities.
And I like how you say that the patients are going to feel the effects of it, because at the end of the day, the data is not going to tell us the whole story, as you mentioned. That's pretty much what you said, because we're talking about health inequalities here, that they don't show up in hospital. They don't show up on that data. But let's get a little bit deeper into that, doctor. When people are most affected by cancer, they're affected by cancer. What is it that they're going to be missing from those researchers or the clinical trials, those algorithms? What is the key thing that we're going to miss here? Being misdiagnosed, I'm assuming, right? What would you say?
Well, so many cancers have different etiologies, but often the biggest issue are specifically, Black, Hispanic, underserved patients are diagnosed late. They're often not listened to. They often, have to keep advocating to get tested. They often, when they are tested and have cancer, they often are not offered this full suite of biomarker testing. Like in lung, we have about 10 to 11 biomarkers now. Most people are lucky if they get 1 to 3 of the biomarkers tested. And the problem with that is we have treatments for those biomarkers, but if you only get 3, and let's say maybe you have a different mutation, then you're going to get put on a therapy that's not going to work, and you don't know. So we need to advocate for this whole next gen sequencing where we broadly sequence the whole tumors, but that's more expensive. But if we don't find a way to get that implemented regularly, we're going to have people that won't be getting optimal treatments that could likely save their lives.
Oh my goodness. And let me ask you this from your personal perspective, from someone listening, from anybody who's listening right now, who's feeling overwhelmed and they're going through a situation like this, they're a cancer patient. From your perspective, what are those few real questions they could bring to their doctor or just their care team to advocate for themselves? What do you suggest that they do?
Okay, we'll answer this from the lens of me not being a clinician. So we don't want to, I'm a PhD, not a clinician, but, as a patient, you want to understand, you want to ask what type of cancer you have, what stage it is, what treatments are available, not just what they say, but what treatments are available, what alternative treatments. And I don't mean alternative as like, types of different water and, some of this stuff can work, but, let's stay with the stuff that is likely we know is going to work. But like what type of treatments are available? Can we do a conservative procedure versus something that may require you to move more tissue? And then, if you can, the biggest thing you can ask for, if you can get one, is either a patient or nurse navigator. Not a lot of places have them, but they will be your lifeline, especially if you're going through therapy and trying to juggle appointments and follow-ups, because they sort of understand what's coming. And often when you're going through treatment, it's the last thing on your mind.
Wow. Well, and thank you so much for sharing that. And I definitely wanted to shift the conversation, if that's okay with you, and talk about your personal experiences, Dr. Eugene, because I'm just going to put it out there. I'm Latina. I'm nosy. You shared your own experiences. Yes, you shared your own experiences. We talk about, the inequalities with minorities, Black, Latinos, but you've experienced medical racism. It's a real thing.
Yes.
It's a real thing. And I want to talk about that because you had mentioned after your foot surgery, your reconstructed foot surgery, I want to know, how did that pain and the mobility aspect of it, what was misrepresented, I can't even talk right now, misrepresented on your medical record that you were like, no, this is crazy. I got to do something about this.
Yes. So what happened is, I had fractured my ankle at the end of December of 2024. And I didn't realize it was right. I knew it was hurt pretty bad. And so I waited 15 hours to go to urgent care because I said, well, let me just get to my apartment and then I'll go later. I don't know what I was doing. I should have went right then.
Oh my God.
Yeah,
bless
I was
your
great.
heart.
And so I went to urgent care, was in a splint, sort of a small splint because they didn't have a boot. I saw ortho a week later. They put me in a boot for 6 to 7 weeks to wait for the fracture to heal. Then I got a call while I was in West Virginia at a funeral to say that they have a surgery opening on March 6th. Now, the surgeon who's a chair of podiatry knows I have an orthopedic biomechanics background, and I've done a lot of years of jiu-jitsu, and I've already torn an ACL. So I was prepared for the procedure. I was prepared for the pain.
Yeah.
All I asked was that I could be given skilled nursing for the first 2 to 3 weeks because I live alone. And because when I was the first week in the splint and I just had the splint and the crutches, I could not do anything. I couldn't imagine, having surgery, being non-weight bearing for 6 weeks and having, one leg that's either with, in a cast and then not being able to put weight on it and having to use a walker or scooter. So I had, and then, you have your leg occupied and you have your two hands occupied either with the handles and so that means you only have one leg and you cannot do anything. You can't wash, you can't cook, you can't clean because you're in so much pain. So I knew that was coming. The surgeon agreed and wanted to put me in skilled nursing. And after we got out of procedure, he said, okay, we'll put this in on Monday. And that was on a Thursday night. And he just needed a nurse, a PT to do a skilled nursing assessment, which should have been straightforward because the procedure I had was triple arthrodesis. That's the technical name, but it's really a pretty invasive bone procedure where they fuse the bones, get rid of bad cartilage, bad tissue and damage, and try to fuse the bones so you don't have any more of these abnormalities. We did the surgery, and then the physical therapist came in and just had horrible bedside manner and horrible attitude. And I could sense this energy right away. And I'm a ADHD empath. I can sense people. And I was like, oh, this is not going to go well. And then she was like, well, you have to get out the bed and use this walker. And now, mind you, I just gotten out of surgery. It was only less than 36 hours before. And she forced me to use this walker, which was not good because I'm already heavily on opioids, wanted me to hop on one leg with the leg that just had surgery dangling in the air. And I can tell you that was the most unbearable pain I have ever had. And I was afraid I was going to fall because, I'm like 300 pounds.
Oh, no.
And I already had a ACL reconstruction on the left leg that she had me hopping on. And she just routinely decided to ignore that. In the chart, it said patient is non-weight bearing. But that does not mean jump and hop. You want me to try to stand up and hop while I'm on painkillers. And then it just persisted that the hospital kept doing other stuff. They tried to give me an early discharge notice that was not given 48 hours in advance. And I took a picture of it and it had 6:30 p.m. on Saturday, but they had it written. But it was written on a sheet that it was 9:35 a.m. when it was given to me. I said, no. They tried to ask about my ability to pay for skilled nursing. Now, mind you, I'm all out of it and I'm not lucid, but they wrote in the chart, he's lucid. And what I learned is if you are, they call it AO times 3. So if you are alert, oriented, and aware, and they assess this for like, if you know where you are, if you know the day, if you know the time, and some other thing.
Right.
So I could answer those questions because I'm not that out of it, but I was not anywhere in my right frame of mind. But because we had that in the chart, they didn't call my medical proxy, which was in Florida. And so I learned that, even though you try to do everything right, if people want to mischart and misrepresent your physical state, they can. And what I learned weeks later is that the physical therapist had written in the chart that patient had no pain and can ambulate.
Oh,
that's what she wrote. 30s.
Are you serious?
Yes, 30s, 12, 24, less than 30s in the chart, which I did not read this until 4 weeks later. She wrote, patient has no pain and can ambulate.
Oh my God, what nerve! you clearly displayed it too. Hello, And
I'm sitting here screaming in pain, and it's funny. And it's not because I'm getting Percocets every 4 to 6 hours, so clearly I can't not be in pain. But this gets into whether it was racism, because, we have this whole history of Black people don't feel pain, but clearly there is no way that I can't be in pain because I'm literally in pain.
Oh my
God. The surgeon was irate, and he still wanted me in skilled nursing, but because the PT had already wrote patient had no pain and can ambulate, and OT agreed, it was a collective effort by the hospital to try to push me out the hospital. And they assume I don't read records, but it took me 3.5 weeks to read my records. But what's most frustrating, everything I said, they just ignored, dismissed, disregarded. And just, so I think, they're in this push to just get you out the hospital. And that's what hospitals tend to do. And especially when they think you have, you're poor, underserved, and don't know anything. And at that moment, I was on Medicaid. And the reason I was on Medicaid is because I launched a nonprofit. So, when you start a nonprofit without money, you kind of have to go through your funds to launch it. So I have no income.
Wow.
But they assigned us our Medicaid. So clearly patient don't know anything. So we're just going to do this stuff to him. the problem is they picked the one who actually knows orthopedics and knows how to advocate and knows how to read medical records. So I saw all the stuff they did after I got home, and that made me even more angry because they said, oh, well, if you go home, we will help you get home aid services. And the surgeon, it took them, the surgeon it took 5 days for them to respond to the surgeon.
Oh my goodness.
They didn't want to answer the surgeon, and because he didn't have direct admitting privileges, they refused to answer him until he finally complained, and then they wouldn't change their assessment because somehow they felt they knew more than the surgeon who did the surgery.
Oh my
goodness. And so because of this, insurance couldn't approve the peer-to-peer because of the PT note, even though the insurance person could not believe this, but because PT said patient can ambulate and wouldn't change their assessment, I didn't get skilled nursing. And if the surgeon hadn't pleaded to get me some home hours of aid, I would have had no aid at all. So I would have been even worse off because they had already said, oh, well, we'll get you home aid services. But if you have already fabricated in my records, then there's no way I was going to get these services. But because though they did this, and it was ugly, and they even on my discharge, they said that he has a caregiver and that he is okay to walk and go to the store. And I'm like, what?
Wow.
So it was epic proportion of, misrepresentation that I've ever seen in my life. And I did write letters. And so I made a whole video series of this on YouTube about what patients can do when you go in the healthcare system. And I'm sorry I'm speaking so long. I'll try to keep this brief.
No, this is very good intel. Thank you, Dr. Eugene,
when
for
you
sharing.
are
Please
so
do.
when you are going into a surgery, there are things you need to do. You need to make sure you understand that procedure. You need to make sure you have a medical proxy that can go to the hospital with you and be there with you and read your records in real time. You need to make sure that right after your surgery, especially if you are on painkillers, do not answer any questions from hospital staff because they would try to get an AO3 on you. Make sure your proxy answers them and you don't say anything because you may, I didn't think anything of what I was answering, but they apparently said I was alert. Want to make sure that if the hospital is not doing what's right, which of course I can't read my medical record because I'm in the hospital in so much pain. You don't think people are misrepresenting your chart, but try to read those records in real time. And then if you see this stuff happening, and you still can file reports. So you officially write letters, certified letters to your hospital leadership, specifically the president, the chief compliance officer, and then whoever was responsible for your care that, you make sure that it's documented. They have to sign it and see it. So they have to write a letter. I did that, but they wrote dismissive letter back to me and addressed me as Mr. as opposed to doctor. I said, oh, so we're going to gaslight.
Wow.
So they dismissed my title.
Oh my God.
They say they did guideline concordant care when clearly they didn't. And then the only thing they wrote is, we gave you a scooter on the last day and we didn't have to. I said, you didn't give me the scooter because you gave me the scooter because you were trying to get me out of the hospital, but you rushed me out and you should have gave me that scooter from the beginning and it may have been a little bit more bearable. So, and then you write the letters to hospital leadership. If it's a joint commission, there's a joint commission for hospital accreditation. If a hospital has done you wrong, you can write and file an official complaint with the joint commission. And you just have to, write every single thing that happened in factual order and submit it. That doesn't mean the hospital is going to lose their accreditation, but if they get enough reports on people with negative experiences, then they will get a more thorough investigation. I file reports with Medicaid for insurance fraud. I file reports with insurance. I filed also with the state of New York. We have a statute of limitations for, professional standards. And so for like physical therapists, occupational therapists, they have a guideline they're supposed to adhere to. So I filed with the Office of Professional Discipline. And so they're investigating the PT because, you have guidelines, your core thing or your life that you should do no harm and you can't make up stuff. So I filed with the Office of Department of Education. And then, and then I kept track of all the letters they sent back and what they didn't do. And then you can also, file with your local representative. But you just want people to know. And then if you're like me, a little bit stubborn, then you can use your voice to advocate. So I've been, I wrote blogs about it. I started little video series, and now I'm on podcasts talking about it because, I want people to understand, this is what actually happens. And this happens to a lot of Black people, and people just don't believe it. But this happens to Black and Hispanic, and you just routinely ignore it. They just pick the person who actually knows how to advocate. But my concern is not just me, because, I ended up getting home and failed the next day trying to get prescriptions because, they wouldn't, I couldn't get prescriptions mail ordered. Like I couldn't get prescriptions delivered from Walgreens because when you're on Medicaid, they won't mail order opioids. So you're like, I have to go get the stuff. And I failed, and I'm like, it was frustrating. So I just want people to know the steps you can take to protect yourself and try to minimize the stuff. But this happens way more frequently than people realize. It's not a one-off. And my concern is not me. I mean, I eventually got COVID, but how many other poor Black underserved Medicaid patients have been in there, pushed out of the hospital early, and then don't know what happened and don't know and didn't read their charts, and then they're readmitted for a complication or something that could have been prevented if they just got the standard of care.
Oh my goodness. And I want to thank you so much for your transparency and what you went through. That is an excellent example of what medical racism, and like you mentioned, the many more people are going through. And also one thing that you highlighted that I'm so glad that you did too, the insurance also is something that they look at as frowned upon. And it's something that makes me think about, let's think about this. A person, let's say a Black mother or a Black family that has Medicaid, we know for a fact they're not going to get the same care as the other person next door in the room that has United Healthcare. Let's be honest. Let's be honest. Let's be honest. And I'm speaking as, at one point in my life when I was pregnant with my son, I'm speaking as a Medicaid person that I had to share my room. A Latina had to share a room while the lady next to me had freaking TRICARE and was able to have her own room with her baby. And I wasn't able to do that. You know what I mean? So just little things like that I'm so glad that you have information out there to advocate and to teach us. And again, I want to reiterate again for our audience member, you have this in YouTube, you wrote blogs, you're out there in podcasts, and also I want to go ahead and let our listeners know we talked a little bit about Medicaid, and you also launched this wonderful nonprofit organization. You founded Check, and it focused on that STEM and the cancer health equity, not just research, but I love it. It's understanding. That's the part that we're missing. So from your perspective, why is it so important to center plain language education and just dignity overall? What would you leave our audience members with on that?
I think the biggest thing, you want to treat people with respect and dignity. And I say all physicians should treat all patients, care providers should treat patients like they would treat their own family. If we did that, we would probably solve half the problems of care delivery. But I also want people to know we create plain language infographics to break down medical information, because I saw what my mom went through navigating care. Yes, I can read my chart, but the average patient sees all these medical terms and they freeze up. They can't read it. They'll be frustrated.
Yeah.
And then your instructions are on page 5, but you aren't going to get to page 5 because you can't read pages 1 through 4. So what we're doing is trying to do infographics on these different medical terms. And then on some of these different cancers, like we do an infographic on a cancer and then a disparity in that cancer. And then what we're trying to do is make sure that we have representation of different people, anything. So if you see, I see myself, I actually will understand this infographic. Like we have an endometrial cancer infographic. When Black women, we have, representative of Black women. And, it's that whole thing. If you see yourself, you might actually be more likely to listen. And the thing with our infographics is when we get them created, we put them through our patient advisory board first, which are a bunch of Black and Hispanic people, to make sure they are accurate, factual, and they're understandable. And then only when the patient advisory board gives me edits, then do we send it to our medical advisory board to make sure it's medically accurate. And then only after that will we put them on the website. So we center community at the whole part of the process, throughout the process. I mean,
Wow. Wow. And if our listeners walk away with that one little mindset shift from this whole conversation, what do you hope they carry with them? What's the key takeaway here that you want to ensure that our listeners just understand that this was educational, enlightening, an eye opener for them? What's that key thing that you want them to take away?
one key thing for patients to take away is you deserve to be treated with respect and dignity, and nothing that happens to put you in the hospital system is per se your fault. You still deserve to be treated with respect, and you are able and you should be able to advocate for the care you're entitled to.
I love that. I love that so much, Dr. Eugene. And I want to thank you so much as we come to a closure for your clarity, your courage, your transparency. I freaking love it. I also want to add in here just for a little information that you also do an awesome annual lung cancer summit that brings patients,
Yes.
caregivers, clinicals, clinicians, researchers, just a whole bunch of people in the same room. Can you just tell us quickly about that before we head out of here?
Yes, so we do an annual lung cancer health equity / intervention summit that's generally focused on Black and Hispanic populations, but it's also other underserved communities. And the ideal from the summit was that, these groups often don't see themselves represented in material, staff, boards, or in biomarker testing and trials. So I said, how do we create an event that we bring the patients, caregivers, and survivors in a space where they can see other people that look like them, learn more about the disease, learn more how to advocate, and then meet people either locally or nationally that are actually vested in the survival of them or their community. So either they can find a doctor locally or they can refer a friend nationally who may have lung cancer and they aren't getting guideline care. And then by bringing the researchers, clinicians, hospital systems, et cetera, in, we have people that are talking about the interventions and programs that they're creating that are removing these barriers. And by putting these people all in the same space, we allow and build that ecosystem so these people don't feel so isolated anymore. So the ideal is to educate, empower, and start building community.
I love that. Educate, empower, and start building community. And the way you remind us that health equity is about people, not just system. I just love that. That gets me like a little vibe in my soul right now. I'm feeling all the vibes right now, Dr. Eugene. He says, you did something to my soul. Before we wrap up, can you tell our listeners where they can find you? I mean, you have such beautiful work out there, and we want to follow you and learn more about CHEK. And actually, where can we make a donation so you could continue this cause, this awareness, and continue with your educational videos and YouTube? Where can we find you?
So you can find the website, https scheq.org. You can also follow me on LinkedIn, Eugene Manley Jr., PhD. And then if you're looking for the org on Facebook, Instagram, and LinkedIn, it's STEMMCHEQ. Those will drive you to us. And I think we even have a YouTube at STEM Check. But literally, I only have the 8-part series I did on the medical racism. I'm going to slowly start adding more content. And then on our website, we have a donate button. We're under fiscal sponsorship, but anything is still tax exempt. So, and then we have, I think we have a newsletter button as well. We're in the middle of trend. We're migrating our website at the moment.
Oh, man, but it sounds amazing so far, everything you've done. And again, Dr. Eugene Manley, I want to really thank you so much for joining in. This has honestly been very enlightening for me and one of the best conversations I've had. I have to say it. I really enjoyed you. So I'm really thrilled that you were able to join us and educate our listeners. So excited. Very, very glad you were here.
Oh my God. Thank you so much. It was a pleasure to be here. I hope it's informative for your audience. And, I see my job is part educator, part empower, and part champion. So and that's how I approach things.
Yes. Thank you so much. That was beautiful. Mi gente bonita, con mucho amor, this has been Conversations with Iris. Take care of yourself. Much love. And make sure you get your health checkups. Take care. Bye-bye.